Next speaker is Dr. Santosh Ambli, and he'll be talking about aortic stenosis and aortic regurgitation. Go ahead, Dr. Ambli.
So thanks to Dr. Suresh, for this kind introduction, and thanks to ACTA as well as Oliver for this promotion. So I start with aortic stenosis now that aortic valve assessment is over. So we'll see how the normal valve looks like again, just a revision. So aortic valve is normally a tricuspid valve. It has got three cusps, non-coronary, left coronary, and right coronary cusp. When the valve is closed, it looks like a logo of Mercedes-Benz. And when the valve is open, it forms a triangular orifice. Let's see at the etiological factors. Etiologically, the causes can be congenital or acquired. Most common cause for aortic stenosis still is a rheumatic aortic stenosis. But in the Western population, senile degenerative calcification is the most common cause. There are certain clinical conditions which may present as aortic stenosis. So as an echocardiographer, it is important that you rule out these conditions which may occur at supravalvular or at subvalvular level. There are also congenital causes, as Dr. Sudhakar already mentioned. The most common congenital cause for AS is bicuspid aortic valve, and let us see how does it look. So it is a abnormality that occurs in about 2% of the population, and basically it is a disease caused by the non-separation of two adjacent leaflets. So most common type is a type 1, which occurs by combination or union of right and the left coronary cusp, and the second type is a union of right and non-coronary cusp. There is one more type, that is type 3, which occurs because of union of left and non-coronary cusp, which is almost not seen, very rare. So we'll see how does the bicuspid aortic valve look like and how to identify it by echo. Just go to the classical mid-esophageal aortic valve short axis view and assess the valve in both systole and diastole. Don't be in a hurry. If you see only in systole, in presence of raphe, the united curve might look like separate. So you might still diagnose it as diastole. You might still diagnose it as a tricuspid valve. So in systole, just see the valve orifice. Usually in bicuspid aortic valve, the valve orifice looks like a this is a type 1 bicuspid valve where there is a union of left and right coronary cusp, whereas non-coronary cusp is free, and the orifice is actually roughly horizontally placed. In case of type 2 bicuspid aortic valve, you will have a vertically placed orifice. What about the unicuspid aortic valve? How do you identify in long axis also? On the left hand side, if you can see, this is a non-aortic valve. If you see here, the coaptation point is exactly at the midpoint during diastole, and if you, during systole, if you see, the aortic valve leaflet almost lines up with the proximal ascending aorta. Whereas in case of a bicuspid aortic valve, on the right hand side, if you can see, the coaptation point is off center, and during systole, they do not line up with the proximal ascending aorta. And also, if you can see, there is a systolic doming. And what about a unicuspid aortic valve? Here, usually it is acommissural, very rarely seen, and the orifice usually looks like a teardrop. And we also have a quadricuspid valve here. This is much rarely seen, and unlike unicuspid and bicuspid valves, quadricuspid aortic valve is usually associated with aortic regurgitation. So now that we have seen these causes, we'll see the calcific aortic cusp. So this is basically a disease of aortic valve leaflets. The etiological factors are basically similar to that of atherosclerosis. So what happens is, because of abnormal shear pressures on the leaflets, there is a degeneration, and this is followed by thickening and gradual calcification. The calcification starts from base to the tips. Here, if you can see, this is the aortic valve in short axis view. The right coronary cusp is involved calcified, and the part of the left coronary cusp is also involved. The commissures appear to be free. What about the rheumatic aortic valve stenosis? You can see here on the left hand side, it's a zoomed view of aortic valve in short axis. If you can see, the commissures between the right and the left are united. And if you can see on the long axis view, there is a involvement of the mitral valve. Isolated aortic stenosis very rarely occurs. It is almost always occurs with the involvement of the mitral valve. Here you can see on the right hand side, there is a diastolic doming as well as dilated LA along with the spontaneous echo contrast. Along with assessment of the mitral valve leaflets, after the morphological assessment is done, just make sure you assess the aortic root also. As you can see on the aortic root side, there is a post-stenotic dilatation. So as you continue examination, after the aortic valve morphology is done, make sure you take the measurements of the aortic root, and no comprehensive examination is complete without taking root dimensions. This can be done simply by taking a aortic valve long axis view at the mid-esophageal level. And after that is done, you have to look for the consequences of aortic stenosis. On the left-hand side is a mid-capillary short axis view showing a severe ventricular hypertrophy. There is one subset of the patients who present with aortic stenosis. They can have marginally increased septal hypertrophy compared to other parts, and these are the patients who actually do poorly after aortic valve replacement because they will have persistent LV gradients. And there are other causes, as I mentioned earlier. Here is a cause, a fixed cause. An example for subaortic stenosis. We have subaortic membrane here. It is a zoomed view of, on the left-hand side, if you can see, this is a zoomed view of mid-esophageal 5-chamber view. There is a small membrane at the LVOT. And to know whether it is causing obstruction or not, just place color flow Doppler on that. And once you see the turbulence below the level of aortic valve leaflet, then you can surely say it is because of subaortic stenosis. Here we have one of the examples for dynamic obstruction. It's a case of HOCM where there is a thickening of interventricular septum. It is also associated with SAM. If you can see the anterior mitral leaflet almost touching the interventricular septum during systole, causing the obstruction. You can confirm that by putting color flow Doppler, which shows a typical Y-shaped color flow Doppler profile, typical of SAM. And we also have one more example here, a 3D view, which shows anterolateral papillary muscle rupture along with the chordae, which is being thrown into the LVOT during systole. Again, it's causing LVOT obstruction. And we have one more example of supravalvular aortic stenosis. If you can see, it's an aortic valve in long axis view. There is a small membrane which is attached to the anterior portion of the sanotubular junction, and that gets carried on to the right coronary cusp. If you put a color Doppler on that, you can surely say the obstruction is occurring because the turbulence is there above the level of the leaflets, and you can diagnose this condition. So once you have done that, you can grade the aortic stenosis. Aortic stenosis can be graded using the Doppler measurements, peak velocity and mean gradient. These are the most commonly used methods to grade aortic stenosis. Along with, they are also more reliable than other methods. You can also measure valve area by planimetry using 2D and also continuity equation by using the formula. So for measurement of Doppler gradients, you will have to use deep transgastric view or transgastric long axis view, and you will have to align the blood flow. Here is an example of aortic stenosis, severe AS, which shows the gradient of around 50 mean. It's a deep transgastric view. You can also do that in transgastric long axis view. Align the Doppler cursor, place the color flow Doppler just to make sure you are at the right plane, and then put the continuous wave Doppler. This patient has both AS and AR. If you see the gradients on the right hand side, it shows it is severe AS. So as I said, the Doppler gradients are quite reliable, and cardiac catheterization is almost never indicated to diagnose grade of severity of aortic stenosis. However, if the echo is unconclusive for some reason, then you can go ahead for cardiac catheterization. For board certification exam goers, there are certain points that you'll have to remember. Echo gradient is more physiological than cardiac cath gradient. Echo gradient actually measures the peak instantaneous gradient, whereas the cath gradient measures a peak to peak gradient. That is done by withdrawing the catheter from LVOT to proximal ascending aorta aortic root. And finally, the gradients obtained by echo, that is a peak instantaneous gradient, is always higher than the gradients obtained by cath procedure. And also, cath procedure gradients usually correlate with the mean gradients of echocardiography. And what are the limitations? If it is so reliable, are there any limitations? There are limitations of velocity method or by gradient method. These can be divided into two groups. Whenever there is an increase in the flow across the aortic valve, there is going to be increase in pressure gradient. And if the transvalvular flow is reduced because of poor LV or sepsis uh, uh, or severe MR, in such cases, the pressure gradient is going to be decreased. In such cases, you are going to underestimate the severity of aortic stenosis. So, is there a method to overcome that? Yes, you can do. There is something called as a double valve technique, where you can uh, get both the VTI of LVOT as well as aortic valve in the same cardiac cycle. Using this method, you can actually calculate the index called as dimensionless velocity index. This is usually indicated in patients who have low flow low gradient AS, who have smaller orifice area, yeah, ejection fraction less than 40, but the mean gradients remain less than 40 millimeters of mercury. In such cases, by gradient will not be able to diagnose whether it is severe or not. So dimensionless valve index give the fair idea whether it is severe stenosis or not. If the ratio LVOT VTI by aortic valve VTI comes less than 0.25, you can fairly say that it is severe aortic stenosis, and it is also flow independent. And what about the planimetry? Yes, it can be done relatively easier method, but in case of mitral annular calcification or severe calcification, it will be much more difficult to identify the aortic valve orifice and to correctly measure the planimetry area. However, when doing a planimetry area, you need to cut the orifice exactly at the tip of the aortic valve leaflets. If the cutting plane is somewhere away from the tips, then you are always going to overestimate the planimetry area. This can easily be overcome by using X-plan, as Dr. Sudhakar mentioned. But if you don't have X-plan, you can still go ahead and do it. Take the metaesophageal short axis view and proceed to aortic valve long axis view. Make sure the leaflet tips are in the center, then drop the angle further back to the short axis. There you are possibly cutting the leaflets at the tips, and you will be able to measure the correct aortic valve area. What about the other methods? You can also use continuity equation, which is based on the principle of conservation of mass. So the primary assumption or the principle is the volume of blood that moves out of the LVOT is equal to the volume of the blood that moves out of the aortic valve. So to get the stroke volume, you have to know the cross section area of the LVOT and the VTI of the LVOT, and that should be equal to the cross section of the aortic valve area and the VTI measured across the aortic valve. So by rearranging the equation, you will get this equation. So what are the things that you need to get the aortic valve area? You will have to have a pulse wave Doppler placed across the LVOT in one of the transgastric or deep transgastric views. Get that, and followed by that, you place continuous wave Doppler across the aortic valve. Once you get that, you have to come back, or initially you have to do a LVOT diameter, which has to be taken at the aortic valve long axis view. It can be done in the mid systole, just 0.5 centimeters below the level of hinge point of the aortic valve. Once you have done that, you just fill in the blanks and you will get the area. But it is not so easy, and it may not be accurate for several reasons. First thing is, it depends upon the Doppler profiles. The exact alignment with the blood flow has to be there, or maximum alignment of 20 degrees is allowed. And secondly, it makes an assumption that LVOT is actually a perfect circle, but in fact it is not. So this can be overcome by doing a 3D evaluation of LVOT area. So what do you look for in 2D? Just look at the cusp number and assess for the quality of the valve, look for the calcification, thickening, and also do the planimetry area and Doppler evaluation, and identify MAC, that is mitral annular calcification. And what do you look for in color Doppler? Look for the turbulence. Make sure it is at the level of the aortic valve leaflets. If it is there below or above, then you will have to think of alternative diagnosis, and you have to find out in other different methods. And look for the associated aortic regurgitation if it is there. And what do you look for spectral Doppler? Obviously, you can get the gradients and velocities, VTIs, just by tracing pulse wave and continuous wave Dopplers, and use them in continuity equation to get the your calculation. Typically, the progression of aortic stenosis is it increases the mean pressure gradient increases by 7 millimeters of mercury per year, and also the area keeps on reducing by zero point 0.1 centimeters per year. Uh, the knowledge of typical progression is actually important, especially when the patient is presented for a cardiac surgery other than aortic valve replacement. In such situations, if he is found to have moderate aortic stenosis, then you may have to consider him for a aortic valve procedure, as the progression of the disease is quite fast. And let us start with aortic regurgitation. Etiologically, it can be caused by intrinsic disease of the aortic crust, such as rheumatic or calcification degeneration, and also myxomatous disease. And it can also be caused by the disease of the root itself. You can see, just like Carpenter's classification for MR, we have Elcoris classification for aortic regurgitation. They are classified based on the leaflet motion, type 1, type 2, and type 3. Type 1 is involving normal leaflet motion, type 2 is excessive leaflet motion, and type 3 is a restricted leaflet motion. So type 1, 1A, B, and C basically involves the involvement of the ascending aorta along with aortic regurgitation, and the disease is graded from above to below as A, B, C, A, B, and C. Whereas 1D is actually a leaflet perforation, which is commonly seen in right coronary cusp, which invariably occurs during a difficult catheterization of the right coronary artery. So we'll just have a look at the various examples of that. Here we have dilated proximal ascending aorta with the dilated sinuses, STJ, as well as aortic annulus, causing severe regurgitation. This is the view. And in this view, aortic valve long axis view, if you can see, there is a perforation of the left or non-coronary cusp, causing the aortic regurgitation. If you can see, there is also a variable degree of aortic stenosis. Here I have an example of aortic insufficiency type 2, that is excessive leaflet mobility associated with the dissection. If you can see, the whole of the dissection flap is moving in and out of the LVOT, causing severe aortic regurgitation. Here I have an example for type 3 aortic insufficiency. This almost always occurs in combination with the variable degrees of aortic stenosis. Finally, this is the endocarditis of the aortic valve leaflets, causing massive aortic regurgitation. So what about the grading? Grading can be done using colored flow Doppler along with 2D at medial level also, and it can also be done using a combination of Doppler and the 2D techniques. Here we have the indicators which are generally done are jet width by LVOT width. More than 65% is called as severe. Then we have vena contracta more than 6 mm, and we have pressure of time and regurgitant volume and fraction based on the continuity equation. So here we have spectral Doppler of aortic regurgitant jet in aortic transgastric long axis. If you can see here, the ARPHT is about 255 seconds. The problem with the PhD is it actually depends upon PhD as well as deceleration time. Actually depends upon the systemic pressures. If the systemic pressures are very high, if driving pressure is very high for the AR, then there can be overestimation of the aortic regurgitation. Aortic regurgitation can be underestimated in case if the LV-EDP is very high. In such situations, pressure off time may not be very reliable. We have an example of vena contract on the left hand side. You can see it's about less than about 8 centimeters, 8 millimeters, indicating the severe aortic regurgitation. On the right hand side, it's a jet width by LVOT width measured at the aortic valve long axis view. To get this, you just get the aortic valve in long axis, place the color flow Doppler, and put the MO right across the LVOT, and then just by measuring the LVOT width and the jet width, you will get the ratio. What about this? This is a eccentric jet, which is causing the jet impingement on the AML. This can be easily appreciated in a basal short axis view. If you can see here, the AML is actually fluttering. To know the exact timing of the flutter, you can use the M mode across the AML. If you can see during diastole here, because it is ECG gated, it's easy to find out the timing. Diastolic flutter is seen here. And you can also use a continuity equation to measure the aortic regurgitant volume and aortic regurgitant fraction. To do that, we have to get the stroke volume of mitral valve. Uh, for the measurement of the stroke volume for mitral valve, we have to take the dimensions at the level of mitral annulus in 4-chamber view and 2-chamber view for the annulus. So that will be D1 and D2. And using that formula, you can also get the stroke volume across the mitral valve. And to get the stroke volume across the aortic valve, you can just do that by LVOT stroke volume, and then difference of it will give the regurgitant volume. And one understated method is holodiastolic flow reversal across descending aorta. Irrespective of the jet, whether it is centrally located or it is eccentrically located, if you are not able to get the regurgitant jet within the Doppler, not able to measure that in the LVOT or by jet width in mediastinal long axis view, you can always go back to this method where if there is holodiastolic flow reversal, as we seen below here, you can fairly be sure that it is a severe aortic regurgitation. Here I have an example for a paravalvular leak. This is a post AVR. This is showing the perforation of the AML post replacement of the aortic valve. But it is always important that after surgery, you go back and assess for the adjacent structures. And what are the limitations that are caused by AR itself? AR can actually.
Could you just wind up in another 2 minutes?
Yes, done, sir. I'm almost done. It actually affects the assessment of other conditions, coexisting conditions. For example, in case of aortic stenosis, it actually overestimates the pressure gradient because of increased flow. In case of mitral stenosis, it actually shortens the mitral PhD and underestimates the severity of mitral stenosis. So this is a mechanical valve in situ. This has been already discussed yesterday by Dr. Koshi, and parasitic valve. And that's it. That's I conclude. Thank you.
Thank you, Dr. Santosh. I'm sorry it was a very difficult topic to cover both aortic stenosis and aortic regurgitation in 20 minutes.